Welcome to Health Policy and Health Promotion Summer 2019 Group 6 presentation of Dementia in the Elderly. Did you know that the elderly can be categorized into three groups, namely the young old, 60 to 74, old, 75 to 100, and centurions over 100 years. Married people tend to have a lower mortality rate than unmarried people. Less than 5% of the older population live in nursing homes, assisted living community, or other institutional setting at any given time, and the people over 85 represent 40% of the older population. According to the CDC, life expectancy has fallen from 78.7 years in 2016 to 78.6 years in 2017, with Alzheimer's disease being the sixth leading cause of death. Dementia is defined by the CDC as a group of cognitive disorders characterized by memory impairment, marked difficulty in the domains of language, motor activity, object recognition, and disturbance of executive function. Dementia is not a specific disease, but a term used to describe a variety of symptoms. Symptoms include forgetfulness, inattentiveness, impaired sleep-wake cycles, psychomotor disturbance, and disorientation. Alzheimer's disease makes up 50% of all dementia diagnoses. Other dementias include Parkinson's-related dementia, Lewy body dementia, and Huntington's disease dementia. According to the Alzheimer's Association, 5.8 million Americans live with Alzheimer's disease, the most common form of dementia, and it is projected that the number will rise to 14 million people. It is the sixth leading cause of death in the United States among adults 18 years and older, and 1 out of 3 adults has dementia. The estimated total cost for health care, long-term care, and hospice for persons with Alzheimer's disease and other dementias is estimated to be $236 billion for 2016. An estimated 15% of people above 70 years old had dementia in 2010, and this number is projected to double by 2050. There are several factors for determining who is at risk for developing dementia. Many adults 65 and over are among the most common, and the prevalence of Alzheimer's disease doubles every 5 years. More women than men develop Alzheimer's and other dementias. Families with a history of dementias are at a greater risk of developing an early onset, and because PCPs do not routinely test for dementias, it may go undiagnosed. People with dementias have other chronic medical issues that can complicate the medical management. Lack of diagnosis can reduce access to available treatments and information. Early diagnosis, medical management, education, and medical community services improve quality outcomes. Factors affecting the health of older adults include access to and utilization of health services such as cancer screening and immunization. Chronic illness results in decreased physical activity. Federal efforts to improve chronic illness services for older adults include programs to fund evidence-based chronic disease self-management education, which helps older adults with chronic diseases better manage their conditions and take control of their health. The Older Americans Act program funds a wide variety of services and supports. They are targeted to low-income older adults and help millions of people maintain their health and independence. The Administration for Community Living supports evidence-based falls prevention programs that are implemented in community settings through aging services and other community providers. The CDC tools and educational materials can assist healthcare providers in reducing their patients' risk of falling. The National Institute on Aging and the Patient-Centered Outcomes Research Institute are testing evidence-based interventions that deploy nurses or nurse practitioners as falls care managers. Approximately 25% of U.S. adults 18 and older reported providing care or assistance to a person with a long-term illness or disability in the past 30 days. Caregivers are at risk for negative health consequences, including stress and depression. Though there is currently no cure for dementia, early and universal screening could help in early detection. Early administration of pharmacological and non-pharmacological interventions would improve the quality of life of the patient and help mitigate the massive caregiver burden associated with the disease process. One tool used to screen for cognitive impairment among older adults is the Mini Mental State Examination. The instrument was developed to assess the baseline mental status of older adults and to evaluate change or decline in mental functioning. The MMSE is based on a 30-point scale that measures level of awareness and orientation, appearance and behavior, and speech and communication. The higher the adult scores on examination, the more intact mental status is presumed to be. A score of 23 or lower indicates a problem with cognition. For Healthy People 2020, there are 4 primary goals. 1. To attain high-quality, longer lives free of preventable disease, disability, injury, and premature death. 2. Achieve health equity, eliminate disparities, and improve the health of all groups. 3. Create social and physical environments that promote good health for all. And 4. Promote quality of life, healthy development, and healthy behaviors across all stages of life. To achieve these goals, we need to increase the availability of existing effective diagnostic tools, decrease the number of people with undiagnosed dementia, reduce the severity of cognitive and behavioral symptoms through medical management, support the family caregivers with social, behavioral, and legal resources, and encourage healthy behaviors to reduce the risk of co-occurring conditions. One major problem in meeting the goals of Healthy People 2020 is the lack of routine screening for dementia. Additionally, the rural and minority population often go undiagnosed. Currently, only 16% of the elderly receive regular assessment screening. Screening tools like the Mini Mental State Examination take a few minutes to be administered and can be used as a baseline for cognitive changes. Though there is no cure for dementia or Alzheimer's, early detection is the key, and medications are most effective during the early stages of the disease. The common theme in the ethical dilemmas related to the care of the patient with dementia is that nursing personnel lack respect for patients who have cognitive deficits. Patients should be informed of their diagnosis and given the opportunity to prepare for their future with dementia. Some ethical dilemmas include informing and explaining dementia diagnosis, enacting a power of attorney, and assistance with end-of-life decisions. In addition, there are issues with safety in the home, hiding medications in food, and therapeutic lying. Obtaining consent and the use of placebos with the dementia patient has raised concern for conflict of interest when designing research and clinical trials over the years. In the early stages of dementia, consent may be obtained, but as the disease progresses, the patient might not be able to remember the permissions previously provided. Perceptions of dementia care and treatment are impacted by mainstream culture, microculture, individual experience, and family experience. But it is important to remember that membership in an individual culture does not mean one necessarily subscribes to all the beliefs of that culture. The barriers to diagnosis and treatment of dementia in the elderly are similar across cultures. These would include lack of information regarding early symptom recognition. Many times the symptoms of dementia are attributed to normal aging, and diagnosis among providers can be challenging. In mainstream American culture, dementia is attributed to biological causes with the perception of the body as a machine. Value is placed on independence, youth, and the notion that aging can be delayed. The caregiver in American culture is more likely to be a paid provider to keep the patient as independent as possible in their own home. This culture is more likely to view caregiving as a disruption in their life plan and a source of stress and anxiety. In the African American culture, the early signs and symptoms of dementia are often perceived as normal aging and is referred to as old-timers' disease. They attribute memory changes associated with dementia to worryation, a lifetime of worry, and to triumph over adversity. In the African American culture, family, extended family, and the church are often the primary caregiver. This culture reports lower stress than Caucasian culture and demonstrate considerable resilience and adaptability. The African American with dementia is most likely to be cared for in the home as opposed to a memory care or long-term care facility. The Hispanic Latino culture shows a great deal of variability in its beliefs and values. Dementia is often viewed as a natural result of living a difficult life. Behaviors like wandering and hallucinations bring shame and embarrassment to the family. Dementia is often considered a mental illness as opposed to a physical disease. The Hispanic Latino culture tends to be a combination of Hispanic Latino culture and modern Western medicine, making it a very complex belief system to navigate. In Hispanic Latino culture, it is important to refrain from upsetting the person with dementia, and the symptoms will frequently be ignored until safety concerns arise. Caregivers are made up of close friends and family. Because there is a limited availability of trained bilingual, bicultural providers, they often do not use the available community resources like daycare and support groups. Because of this lack of support, caregivers report an increased level of burden and distress when caring for the loved one with dementia. The Hispanic Latino culture may demonstrate a strong aversion to nursing homes or institutional care facilities, believing that it is their duty to support the person with dementia. Family holds greater value than the individual. The Chinese culture is shaped by religious beliefs. They often believe that illness is caused by evil spirits or an imbalance in the environment. The personality changes associated with dementia are attributed to fate, wrongdoing, the result of worrying too much, craziness, and/or bad feng shui. Because of these beliefs, they attempt to heal the person with dementia using foods and herbs with yin and yang elements to bring the body back into balance. Unfortunately, advanced dementia is viewed as a mental illness that brings shame and humiliation to the entire family. Clinical practice guidelines are systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. The Dementia Care Practice Recommendations were developed to better define quality care across all care settings and throughout the disease course. They are intended for professional care providers who work with individuals living with dementia and their families in residential and community-based care setting. With the fundamentals of person-centered care as the foundation, the Dementia Care Practice Recommendations 2018 shows the goals of quality dementia care in the following areas. The practice considerations for person-centered care include know the person living with dementia, recognize and accept the person's reality, identify and support ongoing opportunities for meaningful engagement, build and nurture authentic caring relationships, create and maintain a supportive community of individuals, families, and staff, evaluate the care practices regularly, and make appropriate changes. The detection and diagnosis recommendations are to make information about brain health and cognitive aging readily available, know the signs and symptoms of cognitive impairment, and that a diagnostic evaluation is essential for diagnosis of dementia. Listen for concerns about cognition, observe for signs and symptoms of cognitive impairment, and note changes in cognition that appear abruptly or slowly over time. Develop and maintain routine procedures for detection of cognition and referral for diagnostic evaluation. Use a brief mental status test to detect cognitive impairment. Encourage older adults to follow through on the recommendations of their physicians and support better understanding of a dementia diagnosis. Practice recommendations for person-centered assessment and care planning recommend that we perform regular, comprehensive, person-centered assessments and timely interim assessment. Assessment should be conducted at least every 6 months and should prioritize issues that help the person with dementia to live fully. Encourage advanced planning to optimize physical, psychosocial, and physical well-being, and to increase awareness of all care options, including palliative care and hospice. The preferences and wishes of the person living with dementia should be honored in all phases of the disease, even when proxy decision-making is required. To medically manage the person with dementia, take a holistic, person-centered approach to support the person living with dementia and their caregivers. Encourage persons living with dementia and their families to talk to the physician about how to manage comorbidities. Encourage the use of non-pharmacologic interventions for common behavioral and psychological symptoms. Although non-pharmacological interventions are preferred, there are times when pharmacological treatment is warranted for behavioral and psychological symptoms. Encourage persons living with dementia and their families to start end-of-life care discussions early. Having discussions early with the person's physician and other care providers and communicating the preferences of the person and family across care settings can make transition during the progression of dementia more manageable. Early intervention gives individuals living with dementia a voice in how they are cared for in the future, while giving their caregivers peace of mind when making crucial care-related decisions. Highlighting multicultural issues when training professionals and providing guidance for reaching out to these special populations will lead to more effective programs that embrace the unique needs of all care partners. These programs would be especially useful in rural communities where caregivers and individuals living with dementia are often isolated with little access to the supportive services. Antipsychotic and other psychotropic medications are generally not indicated to alleviate behavioral psychological symptoms of dementia, and so non-pharmacological practices should be the first-line approach. Depending on the investment required, some practices developed in residential settings may be feasible for implementation by caregivers in home-based settings. The capacity and needs of persons living with dementia changes over time, and so practices to alleviate behavioral and psychological symptoms of dementia also may need to evolve over time. Therefore, it is necessary to routinely assess the effectiveness of the practice and adapt or implement other evidence-based practices as needed. Dementia is a progressive disease accompanied by progressive loss in the ability to independently conduct ADLs. Needs for supportive care increase over time, such as beginning with support needed for dressing and later toileting and later eating, and must address both the cognitive and functional decline as well as the remaining abilities. In general, people living with dementia are more able to dress themselves independently, so they should be provided with selective choice and simple verbal instructions in comfortable, safe areas. In general, people living with dementia are more likely to eat if, for example, they are offered choice, dine with others and in a quiet, relaxing, and home-like atmosphere, maintain oral health, are provided adaptive food and utensils, and offered nutritionally and culturally appropriate foods. Training is essential for new staff and should be included in ongoing education for all staff members. Develop systems for collecting and disseminating person-centered information. Encourage communication, teamwork, and interdepartmental interdisciplinary collaboration. Establish an involved, caring, and supportive leadership team. Promote and encourage resident, staff, and family relationships. Evaluate systems and progress routinely for continuous improvement. Create a sense of community within the care environment. Enhance comfort and dignity for everyone in the care community. Support courtesy, concern, and safety within the care community. Provide opportunities for choice for all persons in the care community, and offer opportunities for meaningful engagement to members of the care community. Prepare and educate persons living with dementia and their family caregivers about common transitions in care. Ensure complete and timely communication of information between, across, and within settings. Evaluate the preferences and goals of the person living with dementia along the continuum of transitions in care, and create strong interprofessional, collaborative team environments to assist persons living with dementia and their caregivers as they make transitions. In conclusion, just as there is recommended screening for certain cancers depending on age, state and nationwide policies need to be implemented for early detection of dementia through screening. Yearly dementia screening should be routinely and mandatorily administered starting from age 65 for every adult. Medicaid, Medicare, and private insurance should mandate physicians and primary care providers to implement this or forsake reimbursement. Hospitals should provide screening for dementia upon every admission to ascertain any change in baseline from previous admissions, and assisted livings and long-term care facilities should provide screening for dementia. The elderly and their caregivers would be supportive of this policy because it affords them early detection and with medication would delay most of the signs and symptoms of the disease. Universal screening would help curtail late diagnosis, eliminate underdiagnosis of minority and rural folks, initiate early medications to help delay onset of symptoms, offer education of the family members on signs and symptoms of dementia, and reduce the cost by billions of dollars on healthcare in later years due to late diagnosis. Healthcare professionals may object to universal screening because it requires time to screen everyone at risk. The screening instrument is not culturally sensitive and may give false results. It's difficult to administer among non-English speakers and difficult to administer to those with low literacy and the visually impaired. Hiring and training people to administer the instrument could be expensive. Thank you for allowing us to present Dementia in the Elderly. References to follow.